Hello everyone, I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. In this session, I will be discussing a very important topic in the connective tissue diseases, that is the infectious arthritis. So among the infectious arthritis, first let me take up the discussion on non-gonococcal acute bacterial arthritis, right, which is also the septic arthritis. So this non-gonococcal acute bacterial arthritis, first of all you need to know what is the mode of spread to the joint, right? Basically arthritis in the sense, right, the joint is affected. Septic arthritis, it is the infection within the joint, okay? So this non-gonococcal acute bacterial arthritis, it is most often due to hematogenous seeding of the joint. Right, hematogenous seeding of the joint, right, or even the infectious organism can get directly inoculated through penetrating trauma. So the other mode of spread is direct inoculation. Right, the other mode of spread is direct inoculation, and this direct inoculation is by penetrating trauma. Right, but this direct inoculation by penetrating trauma, right, so this is very rare, but it is mainly due to hematogenous seeding of the organism into the joint. Now, what are the key risk factors for the development of non-gonococcal arthritis? The key risk factors are: number one, bacteremia. Right, it is bacteremia. So and this particular bacteremia, it is secondary to injection drug use. Right, and this bacteremia, it could be due to endocarditis, and infections, right, and then infections. So these are the causes for the bacteremia. And the other important risk factors for the development of the infectious arthritis is the presence of pre-existing damaged joints, right, in the sense, like for example, you take in patients with the rheumatoid arthritis, right, so you have the presence of the damaged joints, right, that will be the predisposing risk factor for the development of infectious arthritis. Next, presence of prosthetic joints. Right, the presence of the prosthetic joints, and compromised immunity, right, that is another risk factor. Now, what are the conditions where the immunity is compromised? Number one, in diabetes mellitus. Number two, advanced age of the individual. Number three, advanced chronic kidney disease. Next, alcoholism. Next, cirrhosis of liver, or the patient on immunosuppressive therapy. So these are the risk factors, right? Bacteremia, presence of damaged joints, prosthetic joints, compromised immunity, right? Compromised immunity, you will have that in advanced age of the individuals, diabetics, advanced chronic kidney disease, alcoholism, and as well as the cirrhosis. Now, after having discussed about what are the risk factors for the development of non-gonococcal septic arthritis, let me discuss what exactly are the organisms which will cause the non-gonococcal septic arthritis. The most common organism, right, this is a very important question. The most common cause for non-gonococcal septic arthritis is Staphylococcus aureus. Right, it is Staphylococcus aureus. And this Staphylococcus aureus, it accounts for almost 50% of cases. Right, 50% of causes causing this septic arthritis. And the other organisms next to the Staphylococcus aureus include MRSA, that is methicillin resistant Staphylococcus aureus, and group B Streptococcus. Right, then group B Streptococcus. These are the frequent and important causes of the septic arthritis after your Staphylococcus aureus. Right, then even gram negative septic arthritis. Right, even gram negative septic arthritis, it accounts for about 10% of cases. Right, it accounts for 10% of cases. And this gram negative septic arthritis, it is especially common in IV drug abuse. Right, and it is also common in immunocompromised patients. Right, it is also very common in immunocompromised patients. So this is about the etiology of non-gonococcal septic arthritis, and we have few more organisms which are your gram negative. So you should know what are those gram negative organisms which will be responsible for the development of the septic arthritis. That includes Escherichia coli is one important organism, and another important organism is Pseudomonas aeruginosa. Right, Pseudomonas aeruginosa. So these are the two important organisms which are gram negative, which will cause the septic arthritis. Then you should know what are the pathological changes that you will observe within the joint. The pathological changes include varying degree of acute inflammation, right, varying degree of acute inflammation. And what is that you will observe within the joint is the joint will have synovitis, right, where there is inflammation of the synovial membrane, and into the joint there can be the fluid effusion, right, there will be effusion within the joint, and there can be abscess formation within the synovial or subchondral tissue. Right, abscess formation within the subchondral or the synovial tissue. And for suppose if these pathological changes are not treated, right, if these pathological changes are not treated adequately, then the individual will progress to articular destruction. Right, the individual will progress to articular destruction. So this will be the pathological changes that you will observe in the infectious arthritis. Then what will be the signs and symptoms in case of this non-gonococcal septic arthritis? Let me tell you, the onset of this particular arthritis, it is acute in onset. Right, it is acute in onset, and there will be severe pain and as well as the swelling of the joint. Right, there will be severe pain and as well as swelling of the joint, and there can be also presence of heat of the affected joint that will worsen over the hours. So there will be also increase in the temperature of the joint, right, and this increase in temperature of the joint that will worsen over hours. Okay, so this will be the signs and symptoms of the joint which is affected, and you should know what are the joints which are involved in case of non-gonococcal septic arthritis? Let me tell you, knee joint is the most frequently involved joint. Right, knee joint, it is the most frequently involved joint, right? And other commonly affected sites next to the knee joint will be the hip joint, then there will be involvement of wrist, right? Then there will be involvement of shoulder, and then subsequently there will be involvement of ankle. So these are the joints which are affected. Apart from these major joints, there are certain unusual sites which are affected. And these unusual sites which are affected is sternoclavicular or sacroiliac joint. Right, sternoclavicular or sacroiliac joint, right? These can be involved in injection drug users, right? In IV drug abusers, these particular joints can be affected, right? So the most frequently affected joint is the knee joint, right? The other sites which are being affected is hip, wrist, shoulder, and as well as the ankle. Now, in these individuals, I said you that there will be pain and swelling over the joint, and there will be also increase in temperature over the joint. And because it's an infectious pathology, they'll have high grade fever which is associated with chills and as well as rigors, right? And infection of the hip usually does not produce the apparent swelling but results in the groin pain. Okay, so infection of the hip, right? There will be no swelling. Right, infection of the hip, there will be no swelling. But what is that you will observe? You will have the groin pain. And this particular groin pain, it is aggravated when the individual walks. Right, it gets aggravated when the individual walks. So this is about the clinical manifestations in patients with non-gonococcal septic arthritis. Then, how will you diagnose these patients? That is mainly by synovial fluid analysis. So the investigation of choice will be investigation of choice will be synovial fluid analysis. And within the synovial fluid, you have to check for the WBC count. The leukocyte count of the synovial fluid, it is always inflammatory, and you know, like it exceeds, right, WBC count exceeds more than 50,000 cells per microliter, right, more than 50,000 cells per microliter, and often it is more than 1 lakh with 90% or more polymorphonuclear leukocytes. So as the CVRT progresses, the cells will be more than 1 lakh per microliter. Okay, and most of the cells, 90% of them, they are polymorphonuclear cells. Right, they are polymorphonuclear cells. And another important investigation that you have to do over the synovial fluid is Gram stain. Right, so Gram stain of the synovial fluid is positive in 75% of, right, it is positive in 75% of the staphylococcal infection. Right, next, after the WBC count and as well as the Gram stain, the other important thing in the synovial fluid analysis is the cultures. Right, the other important thing in the synovial fluid analysis is the cultures. This particular cultures, they are positive in 70 to 90% of cases. right? They are positive in almost 70 to 90% of cases. But prior to arthrocentesis, right, prior to arthrocentesis, if you give antibiotics, right, if you give antibiotics prior to arthrocentesis, this will reduce the likelihood of the positive result, right? This will reduce the likelihood of the positive result. So that is about your arthrocentesis, and that is about your synovial fluid analysis. Next important thing is the blood cultures, right? Next important thing is blood cultures. Blood cultures, they are positive in approximately, right, in approximately 50% of patients, right? They are positive in approximately 50% of patients. That is about your blood cultures. Then if you take the imaging tests generally add a little to the diagnosis of septic arthritis. What will the imaging show you? These radiographs or imaging, they will be normal in early stages of the disease, right? They will be normal in early stages of the disease. However, the evidence of demineralization may develop within days of onset. So, as the days progress, there will be evidence of demineralization, right? So that is what you will observe in the imaging in patients with the infectious arthritis. And within the imaging, MRI and as well as the CT scan, right? MRI and as well as CT scan, they are more sensitive in detecting the fluid, right? They are more sensitive in detecting the fluid in the joints, right? In detecting the fluid in the joints. Okay, so that is about the imaging in these patients with the infectious arthritis. And in the imaging, you will also observe bony erosions and narrowing of the joint space. And that is followed by osteomyelitis and periostitis may be seen within 2 weeks. Okay, so you will also notice, right, you will also notice bony erosions and there will be narrowing of, right, there will be narrowing of the joint space, right? So this bony erosions and narrowing of the joint space, it is followed by the development of osteomyelitis and periostitis, right? And periostitis, this may be seen within 2 weeks of the development of septic arthritis. So that is about the investigations in patients with the non-gonococcal septic arthritis. And the next important thing is the prosthetic joint infection. So the prosthetic joints like knee joint, hip joint, these joints also get infected in septic arthritis. So the clinical and laboratory manifestations of the prosthetic joint infection is influenced by whether the infection is early, right? Whether this prosthetic joint infection, whether it is early or whether it is delayed or whether it is a late prosthetic joint infection. So if you see early prosthetic joint infection, when will you consider the word early prosthetic joint infection? It should be within 3 months after the surgery, right? That should be within 3 months after the surgery. Right, that is what you mean by the word early prosthetic joint infection. Now, this early infections present with acute redness and swelling. Okay, I'll discuss that later. But let me tell you, when do we use the word delayed prosthetic joint infection? We use the word delayed if it is 3 to 12 months after the surgery. Right, if it is 3 to 12 months after the surgery. Then when do we use the word late prosthetic joint infection? If it is like more than 12 months after the surgery. Right, more than 12 months after the surgery. This we use this called as late prosthetic joint infection. Now, in case of the early prosthetic joint infection, these patients they present with acute redness and swelling. Right, they present with acute redness and swelling, and usually caused by Staphylococcus aureus and the other important gram-negative organisms. So this is what is your early prosthetic joint infection. Then if you use this word delayed prosthetic joint infection, delayed infections often they present with subtle manifestations, and out of which pain is more common. Right, pain is the common manifestation that you will have in delayed prosthetic joint infection. But only 50% of the patients they will have fever. Right, only 50% of the patients they have fever. Then what are the organisms which will be responsible for delayed prosthetic joint infection? The organisms causing delayed prosthetic joint infections, they are less virulent organisms such as coagulase negative staphylococci. Right, CONS stands for coagulase negative staphylococci. Then Propionibacterium acnes. Right, Propionibacterium acnes, and then the enterococci. Right, and then the enterococci. So these are the organisms which will be responsible for delayed prosthetic joint infections. Then followed by that, the organisms, or what is the organism which will cause late prosthetic joint infection? That means the infection after 12 months after the surgery. And what will be the clinical feature of late prosthetic joint infection? That includes acute pain, swelling, then development of fever. Right, and you should know what are the organisms that will cause the late prosthetic joint infections. These organisms they include Staphylococcus aureus, then we have gram-negative bacilli, right, gram-negative bacilli, and then hemolytic streptococci. Right, so these are the organisms which will cause late prosthetic joint infection. Now, after having discussed about the diagnosis of the non-gonococcal septic arthritis, let me tell you how do you treat these patients with the non-gonococcal septic arthritis. So, the effective treatment of septic arthritis requires appropriate antibiotic. Along with that, the drainage of the infected joint. Right, so one is the appropriate antibiotic therapy. Right, along with that, drainage of the infected joint. Okay. Now, and in case of this septic arthritis, hospitalization is always necessary, right? Hospitalization is always necessary. Then what is the initial treatment that is being recommended in case of non-gonococcal septic arthritis? So the initial treatment that has to be given is vancomycin, and this vancomycin, the dosage is 1 gram intravenously. It should be given every 12th hourly, right? It should be given every 12th hourly. And this vancomycin, which is given 1 gram intravenously every 12th hourly, that has to be adjusted for age, weight and renal function of the individual. And along with that, you need to give the third generation cephalosporin. And this third generation cephalosporins, they include ceftriaxone or cefotaxime. Right, ceftriaxone or cefotaxime, that has to be given. And if it is like ceftriaxone, the dosage is 1 to 2 grams intravenously daily. Right, 1 to 2 grams intravenously daily. Whereas if you see this cefotaxime, it is the similar dose, that is 1 to 2 grams intravenously, and it has to be given every 8th hourly, right? So that is the recommendation for the initial treatment. And this antibiotic therapy should be adjusted when culture results they become available, right? And according to the culture and sensitivity, you need to give the antibiotic therapy. And the duration of the antibiotic therapy, right, it should be around 4 to 6 weeks. Right, the duration of the antibiotic therapy is nearly around 4 to 6 weeks. And as early as possible, orthopedic consultation has to be taken. Then, if you take the surgical procedure, in surgical procedure, like effective drainage is usually achieved through early arthroscopic lavage. Right, effective drainage, it is usually achieved through early arthroscopic lavage. Okay, that is how you will do this surgical procedure, that is effective drainage, and that effective drainage is done by early arthroscopic lavage and debridement. So that is a surgical procedure that you have to do. And you take prosthetic joint infection. The options for treating prosthetic joint infection, it depends upon the time of infection, and it includes the chronic suppression. And even in case of prosthetic joint infection, debridement should be done without removal of the prosthesis. Right, in case of prosthetic joint infection, you have to do debridement without removal of the prosthesis. Right, without removal of the prosthesis. That is how you will treat this prosthetic joint infections. Then, how will you consider, or what is the prognosis in these patients with the septic arthritis? So, the outcome of septic arthritis depends largely on antecedent health of the patient, right? And it also depends upon the causative organism, and it also depends upon the promptness of the treatment. So, it depends upon the past history of the patient, right? And it depends upon what is the causative organism, and third important, it depends upon the promptness of the treatment. right? So these are the things which will decide the prognosis of these patients with the non-gonococcal septic arthritis. And mortality rate is 30% for patients with polyarticular sepsis. Right, mortality rate, it is around 30% for patients with the polyarticular sepsis. And subsequently, as the severity of the disease progresses, or if the treatment is delayed, or if the treatment is inadequate, then bony ankylosis and articular destruction, right, bony ankylosis and articular destruction, they commonly occur if the treatment is delayed or inadequate. So that is about the prognosis of non-gonococcal septic arthritis. So this completes the discussion of this non-gonococcal septic arthritis. So what is the mode of spread of non-gonococcal septic arthritis? It is hematogenous spread, whereas direct penetration, it occurs rarely, right? And you have certain predisposing factors for the development of non-gonococcal septic arthritis. And this particular predisposing factors include the presence of the damaged joint, like in case of rheumatoid arthritis, and the individuals with bacteremia, like IV drug abusers, endocarditis and all, presence of prosthetic joints, immunocompromised individuals like diabetics, cirrhotics and chronic kidney disease. So these are the key risk factors. And the most common organism causing non-gonococcal septic arthritis will be Staphylococcus aureus, right? And then MRSA, group B streptococcus and gram-negative septic arthritis. The gram-negative organisms include Escherichia coli and as well as the Pseudomonas aeruginosa. And pathological changes within the joint include synovitis, effusion, abscess formation in synovial or the subchondral tissue. And if the treatment is not adequate, there will be articular destruction. The signs and symptoms include the development of acute onset pain, there can be swelling and there will be heat of the affected joint, and that will worsen. And the joints which are most commonly affected is the knee joint, and other joints which are affected is hip, wrist, shoulder and ankle. And unusual sites are also affected in case of IV drug abusers like sternoclavicular or the sacroiliac joint. And along with the joint pain, they also have high grade fever associated with chills and rigors. And laboratory findings, if you observe in patients with septic arthritis, synovial fluid analysis is critical for diagnosis. Right, the WBC count, it is elevated within the synovial fluid. It exceeds almost like 50,000 cells per microliter, and it can go even up to 1 lakh cells per microliter, predominantly with polymorphonuclear leukocytes. And the next thing is gram staining of the synovial fluid. Now the other important is blood culture, right? Blood culture also helps you in making out what exactly is the organism. And imaging. Right, in the imaging, MRI and as well as CT are more sensitive in detecting the fluid in the joints that are not accessible to the physical examination, right? And there will be also bony erosions and as well as narrowing of the joint space. Prosthetic joint infection, it all depends upon what is the time of infection after the surgery, whether it is early, delayed or late. Early means within 3 months after surgery. Delayed is like 3 to 12 months after surgery. Late means more than 12 months after the surgery. And this particular infectious organisms that include Staphylococcus aureus and as well as the gram-negative organisms in case of early infections. And delayed infections, they present with subtle manifestations, and the organisms include coagulase negative Staphylococci and Propionibacterium acnes. Whereas late infections, the presentation is with the form of acute pain, swelling and fever, and the organism is the hemolytic streptococci. Right, and if you see the treatment in these patients with the infectious arthritis, that is non-gonococcal septic arthritis, mainly antibiotic, they play a very important role, and then the drainage of the infected joint. Okay, so if you take this particular, the antibiotic therapy, the initial treatment is like vancomycin plus third generation cephalosporin, which is either ceftriaxone or cefotaxime should be given. And the duration of the antibiotic therapy is nearly around 4 to 6 weeks. And the surgical procedure is effective drainage is usually achieved through early arthroscopic lavage and as well as the debridement, right? And if you take the prognosis, the mortality rate is 30% for patients with polyarticular sepsis. So this is about the non-gonococcal septic arthritis. Thank you very much.